Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Sarav Shah from Boston, Massachusetts, United States. Dr. Shah is an attending orthopedic surgeon at the New England Baptist Hospital in Boston, Massachusetts. He currently serves as Director of Education and Research for the Sports Medicine Fellowship, where he was awarded the 2020 Teacher of the Year Award. Dr. Shah received his medical degree from Drexel University College of Medicine and completed his general surgery internship and orthopedic surgery residency at the Long Island Jewish Medical Center. He completed a sports medicine fellowship at the New England Baptist in Boston, as well as fellowship in shoulder elbow at the Hospital for Special Surgery in New York. He holds an academic appointment as assistant clinical professor at Tufts University School of Medicine. He has received multiple education research grants, including the 2019 Mid-Atlantic Shoulder Elbow Society Research Grant and the J. Robert Gladden Orthopedic Society Racial Disparities Research Grant. Dr. Shah serves as team physician for the Merrimack College and Brandeis University. He serves also on the board of American Academy of Orthopedic Surgeons, Orthopedic Knowledge Update Shoulder and Elbow Committee, and also on the editorial board for Arthroscopic Journal. So today is my great honor to introduce you to Dr. Sarav Shah from Boston, Massachusetts, United States. Over to you, Sarav.
Thank you so much for the wonderful introduction. Good morning, good afternoon, good evening. I know we're kind of going live from across the world here. So wanted to talk to you today, kind of a broad overview of evolution biomechanics and a little focus on some of the improvements, mainly for the modern reverse shoulder arthroplasty, namely past 2000, kind of 2010 to 2015, we call modern reverse. So let's get started. So excellent introduction. We can skip that. So normal biomechanics, the rotator cuff compresses the head into the glenoid, and the rotator cuff normally resists the upward force of the deltoid. It serves as a rotational force couple. As the deltoid lifts up, the rotator cuff pushes down. So the problem that we're dealing with is cuff tear arthropathy. We all know the problem. We've all struggled with it. You have a loss of force nucleus where the supraspinatus is out, and there is no force couple to push down to push against the upward pull of the deltoid. So Dr. Neer, originally wrote about this, destruction of the closed joint space, loss of negative pressure, cartilage atrophy, subchondral collapse. Pathology includes instability, superior head displacement, arthrosis, loss of motion, loss of strength. We've all kind of seen these patients and struggled with these kind of patients and felt for them. So the treatment in the past has been non-operative arthrodesis. You see an old arthrodesis here, high complication, high failure rate, high dissatisfaction. So over time, they've introduced, first shoulder arthroplasty was in Paris in 1893. The Bailey Walker is over here from 1973. That was 15 degrees lateralization on the center of rotation, and kind of been evolution since then. The Neer Mark 1, Neer Mark 2 in the 80s, but now the kind of the first generation, second generation reverse was in 1991 with Paul Gramont, the Delta. So the prosthesis is inherently stable, weight-bearing convex portion, and the glenosphere is at or within the glenoid neck. So the key things are the center of rotation is medialized and distalized. So how does it work? The biomechanics of it. So the glenosphere provides a positive stop to restore the force couple. So the upward force of the deltoid is being met by the glenosphere as a positive stop inside the cup. So the reverse serves two main functions: to restore stability as well as to restore function. It does this by the lever arm and the deltoid. So the lever arm distance is increased and the deltoid force is increased by inferiorizing and medializing the center of rotation. That's the original Gramont kind of thesis and idea. So restoration of scapular abduction with torque, force times length. In abducting, the arm is increased as well as you increase the deltoid tension. So lesson learned from this Gramont design have led to the newer design, right? So we're talking past 2010. So glenosphere lateral offset, neck shaft angle, glenosphere base plate positioning, onlay humerus, lateralization on the humeral side, as well as glenosphere eccentricity. So again, these are just the parameters in pictorial form, lateralizing the center of rotation on the socket side, inferior prosthetic overhang from the base plate, changing the depth of the polyethylene, meaning increasing it's semi-constrained, changing the neck shaft angle inclination, and also the downward positioning of the glenoid component, and an onlay component is another kind of modern kind of advancement here. So biomechanical considerations, what we have to think about when we're choosing a prosthesis, when we're making these decisions in the operating room, and preoperative planning has become a big part of this. Deltoid tension, what center of rotation you're going to put, where are you going to put the base plate, how much lateralization you're going to put on the base plate, the neck shaft angle, what stability. Fracture cases have an increased incidence of dislocation, so that plays a role into my kind of planning, as well as implant selection. And then the onlay humerus, as we talked about, lateralization on the humerus is my preference. So deltoid tensioning is crucial to restore the active elevation and implant stability. If you're too loose, there's risk of dislocation. And if you're too tight, there's risk of acromial fracture. So optimal tensioning, we've all seen this kind of sarcomere Blix tension curve. We want to get the optimal tension to optimize the sarcomere muscle. This is just a depiction of center rotation concept. So on the left, the A is the anatomic normal native shoulder. B is a medialized implant. And C is a lateralized center of rotation. But if you notice, any kind of center rotation prosthesis is still medial to the native center of rotation. So that's the key concept here. Even though we say lateralized center of rotation, that's based on +5 from the center of rotation, but it's still, compared to the native shoulder, is still medialized. And that's how the prosthesis works. The reverse works. Just another kind of depiction of that. Medialized and lateralized center of rotation prostheses are both still medial to the native shoulder. So different kind of considerations that we talked about. Inferior base plate positioning is a way to alleviate scapular notching. As we go through this computer models, if you shift the base plate inferiorly, is the single most significant factor in mitigating the impingement of the scapula. What the randomized control trials show that it has to be 2.5 millimeters inferior placement to avoid scapular notching at its most. But again, multiple factors play into that, and a determination has to be made based on the patient for stability, for optimal tension, as well as to avoid, if you're already inferiorizing a lot, if the Hamada fall with a superior humeral head, you don't want to inferiorize too much as a way to kind of increase the scapular spine risk. So it's a plus minus game where you have to kind of find the optimal for that patient. Again, tilt of the base plate has not kind of been shown to be the number one thing. It's the inferior placement of the base plate, but tilt of the base plate definitely plays a role. And inferior is obviously better than superior tilt. This is again showing the motorized musculature, medialized center of rotation, slackens the intact rotator musculature. Therefore, you may lean towards more lateralized center of rotation to kind of retension the rotator cuff. And some studies have shown, this study showed 36% decrease in moment arms of intact rotator cuff musculature with the medialized center of rotation. So neck shaft angle, we talked about the old Grammont was 155. So you have more kind of scapular impingement. Leading, more vertical 135 would lead to less scapular notching. And then the other consideration is prosthetic constraint. So like I mentioned earlier, we'll get through, I actually did the systematic review for the ASCS, American Shoulder Elbow Society Reverse Complications Committee. We did a reverse systematic review for every of the top 9 complications for reverse. And in our kind of 9,000 shoulder study, fracture cases had a higher incidence of instability. So this may be a case where you would use a semi-constrained, and this just shows that the deeper socket is how you get the semi-constrained and increased stability. It's a depth to radius ratio. So the key with Grammont's reverse prosthesis was designed with equal radius of curvature, and that's what gave it inherent stability. And then now we can improve that if you want a semi-constrained prosthesis by deepening the socket, the poly. So this just shows you the difference. So standard poly may have this much depth, compared to the ratio, versus a semi-constrained would have you can see the deeper socket, but still the same diameter, radius. So this is just a case, 64-year-old with cuff tear arthropathy, high riding humeral head, superior bone erosion. You can see the 3D CT scan on the right. This is the prosthesis that I placed. If you can notice, I didn't want to put the inferior base plate too low because then we're already inferiorizing him too much. But what I did was I did an eccentric glenosphere placement, and that was able to get me the 2.5 millimeter offset from the inferior part of the glenoid. And he actually had a lat transfer that I did with the reverse. So this is him 3 months out, kind of doing well without pain, lifting his arm up, and good rotation. All right, so this patient is a 75-year-old female, 4-part displaced proximus fracture. You can see right there. So that's the prosthesis I use. This is actually a different prosthesis than the last patient because this is in my opinion, better stem to judge the height when you don't have the inferior calcar to give you that height. So I was able to fix the tuberosities to the stem, which is crucial in these fracture patients for not only for stability but for function post-op. And this is her 3 months out, I believe. So these patients can do very well. They kind of had a stigma on reverse because of the early complications. But again, that's the first generation. We're talking post 2010 now. So the lessons we've learned from the Grammont have allowed us to kind of improve on this, and we'll go through some of those complications right now. Again, these are the studies that I did with the ASES Reverse Complications Committee. We did a systematic review for the top kind of 11 complications here, and we'll go through a bunch of them here. So in the beginning, the original paper was 2011, Zoomstein paper. This is the most commonly cited and most commonly referred to article. But again, 2011, so you're talking about prostheses that are pre-2010. So at that time, problem rate 44%, complication rate 24%, notching 35%, instability 4.7. These numbers are not great. So that kind of gives the reverse a kind of a bad name and a bad reputation in the country and even the world as a procedure. So the majority of the published studies historically reported on were Grammont style, again, medialized center of rotation and an inlay component medialized humerus. So the lessons learned have kind of allowed us to improve on that in the new designs with multiple options. So lateral offset, lateral center of rotation on the glenosphere, on the base plate glenosphere with eccentricity, as I had mentioned, different neck shaft angles, as well as humeral-based lateralization or lateralized humerus. It has led to a lot of improvements, and we'll get to the numbers to kind of compare it to itself, to the Grammont style. It's quite drastic, the difference. Instability was 4.7, now it's 0.9 with the lateralized humerus in a 9,000 shoulder study that we're getting to right now. I'll show you the numbers. But this study was 2 years ago at a Mayo clinic. So contemporary implants, modern implants, surgical techniques to be improved, very low reoperation rate of around 2%. And every single kind of reoperation, humeral component loosening, dislocation, infection, were all under 1% individually. So prosthesis design, the definitions, is how we relate to it. Medialized glenoid is less than or equal to 5 millimeters per center of rotation. If you're beyond that, that's considered a lateralized glenoid. Neck shaft angle, pros, cons, 135 versus 155. 135, low incidence of scapular notching, increased external rotation at the side, potential biomechanical studies, potential for decreased stability in internal rotation. But again, we have to kind of keep these things with a grain of salt, take them with a grain of salt. Computer model, 135 led to substantial limitation in ER and abduction, abduction. So kind of the newer designs may allow for a 145, 147, and computer models have shown those have the most forward flexion and abduction. The prostheses that I use are 145, and the other one I use is 147. So just going through individually, scapular notching. We all know the Neurath-Cerveau classification for grading of scapular notching. Grade 1 is kind of minor, not really considered clinically significant. But as you get higher, grade 3, 4, once it gets into bone loss and into the inferior screw placement, then that becomes clinically significant. So this was a study that I'm referring to, came out last year in JSES. These 8,000 shoulders in this scapular notching review. So compared, mainly grade 1, grade 2. When you compare our study to Zoomstein study, our study is at around 30%. But if you look at non-Grammont, you're down to 12%. So that's kind of the big take home here is modern design, non-Grammont, 3,000 shoulders, we're not looking at a series of 600 or these other studies are lower numbers, 3,000 shoulders, the total overall global rate is 12%. And even in that 12%, the majority of them are grade 1, grade 2. So clinically significant numbers for scapular notching are way down from the original Zoom scene study. Acromial spine and scapular spine fractures. So the Levy classification, type 1 is acromion, type 2 is in the middle of the deltoid insertion, type 3 is the majority deltoid insertion. So uniformly achieve worse function if you have a scapular spine or acromion fracture. This still holds true, especially for Levy type 3s, because you end up having the concern for a non-functional deltoid with potential malunion or non-union. So again, we're trying to avoid these. There's been argument and debate whether lateralized glenoid or an onlay or lateralized humerus plays a role. In our study, we can actually compare it side by side. There was no statistical difference, still around 2%. So it was 2.8 for the lateralized glenoid, and onlay humerus was 2.2, but not statistically significant. Again, large numbers here. 14,000 shoulders were included in this part of the study. So, we're talking big numbers here. It's hard to ignore when you have these kind of numbers. This was a study we did during my time at HSS, biomechanical study to determine the CA ligament function. And the CA ligament we found played a significant role in dissipating the strain post-reverse. So, historically, there have been some surgical techniques and teachings that you can take down some of the CA ligament during the approach, and it's okay, it's not a big deal, and it kind of just is lost in the wind here. So, but transection generated significantly increased strain on the scapular spine compared to an intact CA ligament. So what that means is, it puts you at a higher risk. So this is just showing the biomechanical setup of the cadaver study that we did. When you cut that CA ligament, you're putting increased strain on the scapular spine. And like we said, that's a Levy 3. That's the most kind of clinical impact if you end up having a scapular spine fracture. This is just the number showing, acromion strain goes down while the scapular spine strain goes up. And that's because the CA ligament acts as a ring to help preserve and kind of keep the strain dissipation intact. The other study we did, biomechanical, was looking at stress rates and scapular spine strains on the acromion and scapular spine in a computer model after doing the reverse. Because historically, you look at arm lengthening, as people would say, is deltoid lengthening, but in reality, that's a clinical kind of surrogate and not necessarily the most accurate. This was a Newcastle shoulder model that has been discussed as kind of way more accurate in terms of it has 5 lines of action that most accurately mimics the deltoid within 0.1 millimeters. So we use this as a kind of more reliable model to determine deltoid lengthening and then correlate that using tech scans on both the acromion and the scapular spine to determine actual strain rates. So this just shows the kind of the threshold is 25. So once you kind of get to 25 deltoid lengthening, that's when you start to get increased strain on both the acromion and the scapular spine. This was using the Biomechanics. So the clinical, people are like, oh, how do you measure deltoid lengthening intra-op? So that's why we incorporated the implant configuration. So if you're using a standard or even a +3 onlay, your scapular spine rates, assuming no osteoporosis and other kind of risk factors of rheumatoid that have kind of been enlightened now, your principal spine on the acromion and scapular spine are not as high. But we weren't able to do repetitive, kind of 1,500 cycles to simulate clinical outcome. So that may be undervalued because typically the threshold for fractures is around 1,200 microns. So this just shows, and historically people have thought just inferiorization increases deltoid lengthening, but this, our biomechanical study shows deltoid lengthening is increased along with strain with lateralization on the glenosphere as well. So in all, zero lateralization, you can see is decreased strain versus +6 in all configurations has increased strain and increased deltoid lengthening. Same thing for scapular spine. And this was an anatomical variant that we found. If you have more posterior appearance on the parasagittal, that actually led to more strain as well. So an anatomical variant that we can see on CT scan may help guide your patients and give them kind of appropriate instructions on whether they might be at risk or might not be at risk for acromion-scapular spine fracture. So we talk about instability. I had alluded to that earlier. You know, the Zoomstein study showed 4.7% of instability rate compared to our study was 3.3. So still statistically significant numbers. But then when you take it down to non-Grammont studies, it's 1.3%. And then you take it down to onlay humerus, medialized glenoid onlay. So, you know, the 20A implant, the Biomed implant, the Exactech implant, the Stryker implant. Now we're talking 0.9%. So you go from 4.7 to 4.9. That's a big difference, you know, under 1% dislocation, when that had been the number one complication and kind of given it a bad name, bad reputation. You know, it is a big time kind of improvement in implants design, technique, surgical technique, and rehab protocols, honestly. And again, big time numbers we're talking here, 9,000 shoulders, almost 2,000 in the onlay group. So hard to ignore these kind of numbers. And again, even statistical difference seen in the lateralized, meaning the lateralized glenoid lateralized center rotation with an inlay versus the onlay prosthesis. Infection rates, just to kind of cover all the bases here, higher infection rates for reverse versus anatomic, but that's just because, you know, probably because to larger implant surface area, large cervical dead space, generalized, you know, these patients are usually sicker than anatomic patients, and the complexity of indications, all comers, right? Fracture versus cuff arthroplasty versus acute fracture versus revision cases have a higher risk of infection. Loosening, you know, in our study, we found much decreased rates of loosening, clinical, not radiolucent lines, but clinical loosening on the glenoid and the humeral components. And again, ascribed to significant advancement in biomaterials is really the reasoning here. Neurologic complications. So, you know, external rotation is glenoid prep and humerus prep has been shown to kind of be the most at-risk positions for nerve disturbances. But the kind of take-home message here is subclinical neurologic injuries by means of intraoperative neuromonitoring and postoperative EMG are common post-RSA, post-reverse, but the incidence of clinically significant and clinically evident neurologic injury is still quite rare. So in our study, non-Grammont is 0.1%. Statistically significant versus the Zoomstein study in 2011 was showed 1.2%. So again, non-Grammont, modern designs, significant decrease in complication rates. And kind of the other thing that we haven't really discussed is, you know, the reason that these complications have decreased is, again, implants, also design, but also the technique, the surgeons are better, as well as the planning softwares, right? So we're planning what we're seeing preoperatively, and we're better prepared for what we see intraop, and there's less surprises, more reliable outcomes. So this study, you know, just as a caution, because, you know, you have to look at both sides as we teach the fellows in our program here. You have to look at, you know, 3D planning is definitely an advancement and a help, but you have to take it under advisement and take it with a grain of salt. You have to still trust your training and trust your education and your own surgical skills versus the computer all the time. So the first study was Denard in 2018, high inconsistency of version inclination versus the automated study, which is 20-year blueprint, versus all other studies are all manual landmark based, where an engineer makes the plan for you. The only automated one is blueprint from 20A. So in our study that I did in 2019, we looked at automated versus, again, another manual landmark. This, just in this case, was the Arthroplasty VIP one. The cases varied in blueprint 65%, in VIP 45%. So large numbers. It varied in either inclination or version, varied by 5 degrees or more. And we used a control of a 3D printed model, 3D printed scapula, where we measured based on the CAD scan, which is accurate to 0.05 millimeters. So, you know, comparing that to the biomechanics 3D printed model, you know, that's a large variance. So again, your eyes, your training is always going to be your number one that you trust. Just showing the research. Thank you very much for your attention. Thank you. I'll take any questions. I'm not sure how this kind of works.
Thank you, Sarav, for that fantastic lecture. A lot of new information, and congratulations for all the publications that you've churned out in the last couple of years.
Thank
Few
you. Thank you.
questions. Yeah.
Yes, sir.
What about stemless components? There are some surgeons in Germany, they are looking into stemless components, and they said that in case it requires a revision, it becomes a much more easier procedure. So what is your take on, do we have data to say a stemless reverse shoulder or a total shoulder has an advantage?
That's an excellent question. That is really the hot button topic of all the conferences, virtual this year, but all the conferences recently. So stemless for anatomic, I would say yes. So in my patients under 60 with primary OA, intact cuff, you're getting a stemless anatomic. You want to look at the data for anatomic, 11-year outcome for the Arthrex Eclipse, 11-year follow-up, no humeral loosening. So there's only two types of stemless, either screw type, which is the Arthrex Eclipse, versus the impaction type. Everyone else is kind of the impaction type. The Exactech is a 3D printed version. Tournier has a version, but those data is only kind of 6 or 7 year outcomes. They're actually using the old Biomet as their 7 to 8 year outcomes versus the Eclipse is the same implant 11-year outcomes. We actually hopeful to get this grant. We're doing a stemless comparison because the holdback and kind of the reservation has been in osteoporotic patients. Can we use a stemless in osteoporotic patients? The earlier kind of Atwell studies, George Atwell studies have been showing that he was concerned that most important bone is right under subchondral, but in reality, that may not be the case if you have stronger fixation now. So we're doing that study in our lab now this summer, and we'll hopefully be having that coming out soon. But to answer your question, reverse, I would say no. The mechanical forces at the stem are too great at this time with what we have to be able to hold a reverse. Biomet tried that with the tests, did not go well. High revision rate, high complication rate. So no, I would not advocate for that, a stemless reverse.
Thank you, sir, for that. And also, reverse is really caught up among shoulder surgeons. Do you think there are some indications where a total shoulder would still have an advantage over the reverse? For example, the classic indication for a reverse was a rotator cuff tear arthropathy, and now the indications have increased. But are there indications where an anatomic is still superior? For example, arthritis?
Yes, so that is another hot button topic. You keep this is literally the hot button topic. We argue. So I have my colleague in the other kind of competing group across town. He's a big advocate for reverse for primary arthritis. So that was kind of my goal because HSS has a great shoulder database from all their surgeons. So we were able to put this together. It actually should be in the next month orthopedic journal. We looked at MCID and so, but MCID is kind of the one standard deviation, right? We want to make our patients better, and that is the 100%. That's the basement, though. That's the minimum that we should get. But we always try and go for best, right? We always try and go for excellent outcomes. So excellent outcomes is demarcated by 2 standard deviations. That's substantial clinical benefit, or SCB. So we actually compared anatomic for primary OA versus reverse for cuff tear arthropathy. So different indications, but when you look at anatomics for primary OA intact cuff, you have a 90% chance for achieving SCB versus reverse, it was 70%. So even, and these were patients over 75 even. Patients, that you would think, kind of high risk of cuff failure. These were 2-year outcomes is what we had, but still 90% achieving SCB is excellent. So yes, there's definitely a role, and I would advocate highly because these patients, they're not perfect after reverse, right? But you can theoretically give an anatomic to a patient and they can be happy for 10 years, and happy meaning almost a normal shoulder. That's the other study. We're collecting data now. These patients that we get here are kind of more aggressive than I would say Europe or Asia or in India. They're going back to weightlifting, like aggressive weightlifting, bench press, 150-pound bench press, and just going against surgeon advisement. They're still doing these things, and they're doing fine. We have right now we have 5-year data, no loosening, no component failure. We had 2 cuff failures, but out of 120 patients that we have, that just shows you the durability of the anatomic replacements now. So I would highly, highly advocate for that. These patients are very, very happy getting back to a normal life with their children, lifting kind of normal everyday activities, golfing, return to sport is much higher for anatomics. So yes, I am firmly on the anatomic side.
Thank you, sir, for that. Reverse shoulder is a major surgery. There's a lot of metal in there and there's less bone available. Suppose it requires a revision for some reason, bone loss, how difficult it's going to be?
So I can tell you with my experience, at the new guy in Boston here, I get everybody's revision because they don't want to do it. But so I've actually revised, even in the past 6 months, I've revised 10 reverses to reverse. So the Mayo Clinic had a paper that came out, I think a year and a half ago. Revision reverse is a good 75% MCID from revision reverse to reverse. It's a technically demanding procedure. That's no doubt about that. You have to be able to be comfortable with an osteotomy, right? In order to replace, if you have a loose humeral component, it may be loose on CT, but in reality, clinically, it's not going to pop out. You have to do a lesser tuberosity osteotomy all the way down, always make a step cut across. If you don't make a controlled step cut, it will break and fracture spiral all the way down. Then you're in for a big nightmare in the OR. So technically demanding, especially if you're revising these, theoretically, these are older, they're cemented prostheses, kind of pre-2010. So that's always torture getting that out. But if you talk about kind of bone loss, I found that, with the modern stuff that we have now, you're able to get away with it. So the last guy that I did with large, so we took out the base plate because it had base plate kind of cross welding with the screw, and the whole thing was moving. So we took out everything, took out all the base plate, took out the screws, obviously glenosphere tray, stem was well fixed. We left the stem, but getting in, so I took a femoral head allograft, and you kind of treat it like an oats. You get the allograft, the Arthrex harvester, and I put 3 10 plugs, and I took some BMAC, injected the BMAC in there, and then you put the injectable cement. It's either Cerament or Trabexis is the other one. And then hardened, and it's drillable after 10 minutes. So with allograft, BMAC, and Cerament, drilled it, put a base plate in. He's now a year and a half out. Good range of motion. He's not 160, but 130, 140, good range of motion, pain-free, happy. So if you're comfortable with it, if you do it, it's very technically demanding, but it does fare pretty well.
Thank you, sir, for that. Just one last question before we wind up the session. We have a lot of fellows and residents on our channel. And just to recapitulate something what you have discussed, what is the fundamental difference between a Graham design and versus a non-Graham design?
Fundamental difference is medialized glenoid inlay humerus at 155. So nowadays, whether you do DJO is lateralized center rotation and 135 inclination. If you use a Biomech, it's still medialized, but but it's still lateralized a little bit compared to the Grammont, so +3, +4, and an onlay humerus at 145. Same with Tournier, same with Exactech. So biggest difference is we don't want an inlay with a medialized glenoid.
Okay, thank you. I think that's all the questions that we have for the session. Fantastic lecture and really great number of publications from your side during this difficult year. Thank you so much for joining in, Sarav.
Thank you for having me. Let me know if there's any more questions. You can always email me and contact me. I'm happy to answer any more.
Sure. Bye-bye.
Thank you.